All right, it looks like mostly everyone's connected to audio now. So we're gathered here today for the Esas group counseling session today. It's going to be presented by Steve Steiny from the American National ATTC Addictions Center. He's up there in the top left. So the American Indian and Alaska Native Addiction Technology Transfer Center is a part of a larger US-based ATTC network. This slide right here with the map shows where the regions are and the centers for each of the ATTCs. And so this is a product. So the National American Indian and Alaska Native Addiction Technology Transfer Center is supported by a grant from the Substance Abuse and Mental Health Services Administration, SAMHSA. And the content of this event is the creation of the presenters, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native ATTC. And following today's event, you are also going to receive a follow-up email, which will have links to the presentation slides and the recording, which will also be on our YouTube. There's information about how to request CEUs. And I believe there should be a link to our evaluation survey, a GIPRA link, kind of towards the end of the meeting. And then if we could just have everyone read this for a second, because although we are gathered virtually today, we want to take time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. So we would ask that you please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll of the Meskwaki and Winnebago nations, and then Sean A. Bear from the Meskwaki Nation. All right, thank you for taking some time to read that. It's really important to our center. I'm also going to be introducing today's speaker, Stephen G. Steiny. He's the project manager at the National American Indian and Alaska Native Addiction Technology Transfer Center at the University of Iowa's College of Public Health. Steve earned his bachelor's in communications and his master's in the substance abuse counseling program in 1997 from the University of Iowa. He's been a certified alcohol and drug clinician within the state of Iowa since '97, born and raised in Iowa, and has worked in the behavioral health services and nonprofit sector for 23 years. Since January of 2019, he's been working for the National American Indian and Alaska Native ATTC at the University of Iowa and has been in recovery for over 35 years. And then I'm going to hand it off to Steve. I'm going to stop sharing my screen for a second.
Well, thank you very much, Parker. Parker is one of our communications team's staff members, and appreciate your help and support, and I appreciate the introduction. Great to see everyone. I want to just say good morning or good afternoon, depending on where you are and where this broadcast finds you. I'm really thrilled to be with all of you. I've got some information I want to share with everyone today, and some of you may have some experience, some clinical experience, or maybe practicing in the field, and so some of this may be review for you. Others that are entering the field, or perhaps working in a peripheral field, or thinking about entering the field and working with substance use disorder treatment centers or patients or related behavioral health fields. This might be a nice way to add to your building of your knowledge base as you get ready to enter the field. So we're going to cover quite a bit of information, and what I'm hoping to do, there's really 2 parts to this presentation, and the first part will really spend kind of looking through and looking over sort of the how-to, the nuts and bolts of what makes up group counseling or group therapy. And then the second part, I'm really going to be asking the audience to consider some of the components to the second part. The second part of the webinar today will be specifically talking about working with Native American or Alaskan Native patients in group settings, some things, some considerations, some things, some cultural considerations to make note of. And what I would ask the audience to do as we get ready to kind of walk through this together and share ideas and information is I would ask that if you are a clinician providing services and working directly with Native American or Alaskan Native patients, I may turn to you as well and ask for you to share some of your own experiences and to help confirm and have a dialogue today. So I just want to give you a heads up on that. And as Parker mentioned, there'll be a short survey at the end. You're not obligated to complete that, but we sure would love to hear back from you. It helps us to make improvements and to continue doing things that you appreciate or that we're doing well. We can continue to build on those. What I want to do now is see if I can get my screen up and get the right view going here without breaking anything. I've been known to break Zoom once in a while. It happens, you know, I don't know. But I've got Parker here in case my Zoom blows up. Parker can swoop in and get me back on track. How does that screen look to everybody? We've got a full screen there.
Looks great to me, Steve.
Great. I see some head nodding and I got confirmation from Parker. So that is fantastic. Once again, I just want to say I appreciate everyone's attendance today. It's good to see some familiar names and faces. And what we'll do is just kind of move through these slides, and you know, you're free to unmute and ask some questions, or use the hand raise feature, or certainly utilize the chat box. Parker and I can kind of keep an eye on that, but I'm happy to stop and take some questions. And like I said, in that second piece of the webinar today, I'm going to turn to the audience too to help me with some of the cultural considerations in working with Native patients in a group setting. So let's go ahead and get started. So today's essential substance abuse skills training, the focus will be, as we've mentioned, will be on group counseling. And those of you that have sat for your licensure or certification exams know that many of our Esas curricula are based on the 12 core functions or 4 domains of counseling, and will sort of mimic or parallel that in many ways. So some of this information, like I said earlier, may be familiar to you. So let's go ahead and get started. And as I said, if you have questions, utilize the chat box or simply unmute or use your hand raise feature, and we'll try and stop and process a little bit. So here's what I was referring to. We're going to look at, there'll be 2 parts to today's discussion. One will be looking at the sort of the components of I want to say the nuts and bolts, or the how-to of how groups work, what they are about, different types, the different stages of development that a group goes through, and then some facilitation guidelines or suggestions on providing group. Let me just ask the group now, how many, we've got about 40 of us here. How many of you are currently providing group services to your patients that you're working with? Maybe just see some hands, or how many of you are providing groups? I see Roger's got his hand up there. Yes, I see there's a few hands going, and you can use the hand raise feature, one of the reaction buttons, to help me understand a little bit more. Yes, I see Yolanda's saying that yes, she's doing, and Catherine. Good. So the reason that in part what I want us to keep in mind too is how important group having groups in a treatment center or in a within the curricula that you're providing for patients. There's something extremely meaningful and valuable about having the patients meet as a group and share experience, strength, and hope and ideas and offer support. There is nothing, in my opinion, more powerful than that connection that happens when peers can support peers and understand and empathize with one another in a group setting. That's not to say that the facilitator doesn't have a role, but I want you to imagine any of you who have worked in a residential facility. I know in Iowa, state licensure says you have to have 50 hours of direct services a week per patient. Now imagine trying to do a residential facility or trying to run a residential treatment program without groups. I think it would be probably impossible to do. You could do it, but there would be so much individual work that the power of the group would be lost. So just something to consider as we walk through and talk a little bit about group dynamics and the components of group counseling within the behavioral health field. And certainly fields outside of that, but we're going to focus primarily on substance use disorders, mental health, and other related behavioral health components or services. So let's take a look now at some of the different types of groups. And some of these are going to make sense to you, and you might be able to identify which type of group or groups that you have maybe done in the past or are currently doing. There's the psychoeducational group, and I think this group I think of when I think about psychoeducational groups, I think about an early intervention setting, or perhaps an entry-level outpatient setting where there's an element of education and information, but there's also a therapeutic component because you are meeting as a group and processing maybe a topic or doing activities as a group. But this, I think, I would equate to an entry-level outpatient experience or perhaps an early intervention. But this type of psychoeducational group is often used to address substance use disorders or other behaviors related to that in their early stages. And the facilitator in this group really takes on that role of teacher or sort of educator, and but there is a therapeutic component to that. Another type of group to consider when we look at the different types of groups is a skill development. And the purpose of this group is to specifically develop skills that the patient may need to stay on their recovery track or to achieve their early recovery goals. It really takes on a cognitive behavioral sort of approach. In other words, how are your thinking patterns and your perspectives influencing or impacting the things you're doing or your behaviors? This type of skills development group can be infused even in a psychoeducational group. So there could be some overlap or some combination of these different types of groups. But can anyone think of, if you want to throw something in the chat, can anyone think of a type of group or a type of skills development or maybe an activity that you would do in a skills development group? Anybody have an example they would want to share? I can kind of watch the chat too. Something where you're practicing a skill or introducing a skill or practicing a skill as a group. Anybody have any examples or suggestions that they've used? I'll let you think about that for a minute. An example that I might suggest, and one that was used. Okay, here we go. Yeah, Catherine says yes, exactly. That's where I was going as well. Catherine was practicing refusal techniques, maybe in high risk situations. That's a great one. Active listening, yes, that's great.
So one of the things we do is
hi, Albert.
Hey, how you doing? Albert
Good.
Tedman, the Shingle Springs Tribal Health and Wellness. One of the things that we do is along the lines of active listening and developing refusal skills. The art of saying no, we say, is we do like a fishbowl. So we do talking circle format.
Mm-hmm.
And of course, we smudge, we burn medicine. I work on the reservation.
Yeah.
And that right there is an actual skill, is to teach folks how to get centered, how to get grounded. And then it's the way we open all of our groups and classes. But we do vignettes. And in the vignettes, we have already taught how to say no, the art of saying no, refusal skills, and then we let them practice using the use of vignettes. So that's kind of one of them.
Yeah, that's fantastic. I remember doing a youth group years ago. I worked a lot with adolescents and young adults, and we practiced a refusal skill where we passed around a bucket of freshly popped hot popcorn. And the challenge was to refuse that, even though it smelled good and it was right there. And not everyone was able to pass the bucket without maybe taking a handful. So it was one of those applied skills that was safe to practice, but it still had a lot of the elements of what it's like to be, in that situation where you're impulsive, or you can smell it, you can see it, you can, so. But I appreciate those comments. Some of the other types to consider, and I think again these could be combined with the earlier types of groups, would be this cognitive behavioral group, where the facilitator is really focused in on providing that structured environment within the group, within that group, so that the members can examine and really process and look at their behaviors and some of the thoughts connected to those. This can be a very powerful group. My early experiences were using RET or REBT, where you're taking irrational thoughts and sort of diffusing them. And doing that in a group setting can be very powerful. And then, of course, support groups. This I think, at least for myself, when I think about this sort of traditional kind of self-help group structure, we know that there are a lot of pathways to recovery, but these support groups often can be a really important element in our patients' early recovery process. So whether it's the family members connecting with other family members, or whether it's the identified patient connecting with the recovery community, or with perhaps a mental health support group, or a grief and loss group, these support groups can be absolutely vital. And they really help to sort of undo some of the stigma that is connected to reaching out and asking for help. So really, really important different types of groups to consider. If you can think of another group that maybe I didn't mention or that we got to add, let me know. We can consider getting that added on. I want to talk about two different types of group. This is called group membership, but I want you to think of it as really these broken up into these two different types of groups. And I know for myself, in my practice, we often utilized open groups. There were occasions where closed groups were implemented, but by and large, I think it's fair to say that most treatment facilities will offer open groups. In other words, there are new members coming in and veteran members or members that have completed the group or the program exiting at different times. So it's perpetually changing. And a closed group means that everyone starts at the same time and everyone would complete at the same time. And there are pros and cons to both of those types of groups. I personally, for a number of reasons, really preferred that open group setting so that there weren't people waiting to get in. And it also allowed for senior members or experienced group members to really help orient and connect with newer members coming in and may have some anxiety or concerns about being part of a group. So here we can see, I don't have to read these out to you guys, but just so you can kind of see the different advantages and disadvantages connected to providing these different types of groups. As a group, with the audience, are you all providing mostly, is it mostly open groups, or are there cases in your facility or your program where there's closed groups? Anybody want to comment on that? Mostly open groups, folks doing mostly open groups that are providing group services. Yeah, I see Nick nodding his head there. It tends to be the preferred method from a customer service or a patient service or best practice standpoint, to perpetually being able to, if I'm with a patient in an assessment or an admit, and I can say to them, well, how would you like to start group, tonight? And I can walk them right down to the group, introduce them to the group, and they're in, as opposed to saying, well, our next group cycle doesn't start for 5 weeks. You're going to have to wait. That can cause a lot of problems therapeutically, and it can be an ethical dilemma as well. So open groups, in my opinion, are really best practice. But there are times where closed groups are important and play a role. So I don't want to dismiss closed groups completely. Anyone else want to comment on that? Yeah, Albert?
Yeah, for us, we have open groups. So in our MAP program, the services are, we provide them in phases. So phase 1, phase 2, phase 3. And those are open. Folks can join at any time. And process through the pathway of care. But in our closed groups, some of the closed groups we offer are they have timelines. So let's just say, for example, this is a 12-week session. Yeah. And if you miss the first 2, then you're playing catch up.
Yeah.
In some of the groups that we offer. And so then we have rules on when you can participate, then the group is closed.
Of course.
And it'll cycle, like you're sharing those groups, that then it'll recycle.
Yeah.
And so there are the pros and cons. And then we offer 12-step on the reservation.
Yeah.
And so on the reservation, it's not a large res, so the population of the groups are always manageable.
Sure. Yeah.
So that's kind of one example.
No, I appreciate that, Albert. And I think I know one of the strategies we used with our closed groups when we did implement them, or when we piloted those, were to have maybe 2 or 3 cycles occurring. So I might have one group that starts and goes, and then I might start a second group that's also closed, but on a different time cycle, so that it reduced wait times and delay for entering the group setting. But to supplement it with 12-step or other, Wellbriety or other group support groups is also an option. I appreciate that. So there's some things to consider as well. Before I, as a clinician, before I am putting a patient into a group setting, there's some things to consider. And these are not set in stone, but rather just some things for you as a clinician or provider to consider. Let's look at the patient's readiness. And again, I think placing a patient who might be what I would call in a pre-contemplative stage of change into a group is not necessarily ruled out or a bad thing. But I may want to consider that when I'm looking at group placement, and level of care and other components in the assessment process may also help guide you when considering whether or not to when and what type of group to place your patient in. But I would also look at the patient's characteristics, needs, and preferences. Sometimes if you get a self-referral or somebody that may have some options, sometimes you need to really listen carefully to what the patient is requesting or what they prefer. And the patient may need to move to different groups as they progress throughout the treatment process, or whether they encounter setbacks. So, for example, if I have a patient in an intensive outpatient group, and then let's say that's a 4 to 6 week engagement, and they're progressing nicely, they are reporting abstinence, providing negative urine screens, and engaged in the group and making progress on their goals. And I may reach a decision with the patient that will step them down into an extended or continuing care setting after 3 weeks. Or if they're struggling, we may extend their intensive outpatient group involvement and then reevaluate and step them down into continuing care at a later time. I think it's important to be flexible, but to consider the appropriateness of somebody actively using or struggling with comorbid or co-occurring issues. It may be in their best interest to take a break from the group and connect with you and reevaluate their needs, rather than having them in a group setting where it's causing them distress or causing the other patients concern. I hope that makes sense. Again, these are just some suggestions or considerations when we're talking about patient placement in particular group types. There's another sort of dynamic here that when we think about this a lot, and it's I would say self-referral versus mandated. In this case, we're going to say voluntary versus involuntary. Now, I don't know about what the kind of work you all are doing specifically, but I would say, anecdotally, 85 to 90% of the patients that I saw were referred through some third party, corrections or DOT or family or employer. So there weren't a lot of self-referrals. Most of them were mandated into services through, the system that they were involved in. So if we look at group dynamics, though, in an involuntary group or a mandated group, the patient's sort of being pushed into this group involvement, and there may be some disruption or some resistance to being involved in the group, but they may have a better experience and a better overall outcome in the end. One of the things that I found really striking was there was some research done on treatment outcomes, and they looked at a group of mandated patients versus a group of self-referred patients. And I was really surprised to see that the outcomes, the treatment outcomes, in other words, success or measured success after the primary care, was about the same for both groups. And I found that very interesting. But some of the things to consider with a mandated or involuntary group is there may be some legal obligation. There may be employer or family concerns that are pressuring them, or there may be other sort of external factors that are pushing them into this. And the patient's readiness to change may be impacted by that. They may not be ready to make the changes that everyone else seems to think that they need to make. This can be this can be a powerful dynamic in a group to help create some dissonance and realize maybe that there are more problems there or more issues than they initially thought. Self-motivation to change can inspire others in the group and positively impact the group culture and norms. In other words, if you have a mix of voluntary versus involuntary patients, sometimes that can really be a powerful combination. The mandated patients may see and understand something a little differently to someone who's there of their own volition and for their own reasons. Again, we look at the self-referred or voluntary. The voluntary group members, they can often, again, act as sort of, they can assist or act as kind of a motivator for patients that are less ready to change in the earlier stage of change, if we want to use that label as a pre-contemplative or contemplative stage of change. And they can also serve as mentors or role models to maybe a mandated patient who really hasn't seen that type of openness to change. And lastly, just self-motivation to change can, as I mentioned, inspire other group members and impact the group and cultural norms. So those are some things to consider. I think the takeaway from this is you're going to have a mix oftentimes in the group. It may be majority mandated patients, but to have self-referral in that group, it's workable, and it can really add a richness and a depth to the group dynamic. Some other things to consider. Patients often indicate primary mode of help is through mutual support. And that's, again, it goes back to what I said earlier about the power of the group. I could tell a patient, gosh, you really ought to take a look at that. But if my peer is telling me, gosh, you really should take a look at that. I went through the same thing 2 months ago. That's powerful, and really is at the heart of what the group can offer, especially to substance use disorder patients early in recovery. So as I've already said, that's not really the facilitator that's the most important part of the group, but that mutual support, the people connecting with each other, the individuals connecting with each other. That idea, we can relate. You want to see, your group members or your peers. And this can be outside of a clinical group too. It can be in the form of, if we think about, interest groups or book clubs, or, maybe a Weight Watchers, or, other groups outside of maybe a clinical setting where there's a connection, a common interest, a shared purpose or goal. Other things to consider about group membership and who's involved is those members who self-reported improvement were significantly more likely to have felt accepted by the other group members. And there may be specific references to particular individuals when asked about their group experience. And then this perceived similarity of some kind among the group members. So as I mentioned earlier, this common purpose or this bond, this sort of universal bond. Some people are going to feel more committed to particular individuals than others. So those are some things, again, to consider. And let's look at, again, self-help versus mutual help. And there's some differences here. Self-help sort of suggests that the individual in treatment is the main contributor to the change process. Whereas in a mutual help, it means that the individual also assumes a partial responsibility for the recovery or well-being of their peers. So there's a subtle difference there. I think there's some overlap as well, but things to consider when we look at self-help versus mutual help. Let's talk a little bit about the implementation of groups. As facilitators, we have some responsibilities, and I think most of you may be able to relate to many of these. One of our roles, or one of my roles as a facilitator, is to sort of establish those guidelines or those parameters for the group. Why are we here? Providing some general expectations, and to clarify that purpose of the group. Why are we here? I might ask that rhetorically to a group that's just beginning, or we may revisit that. I had a men's continuing care group where we would often sort of ask ourselves or remind ourselves, why are we here? What's the purpose of the group? This is also referred to in some circles as the norms, to guide the group's behavior or process. So instead of using terms like group guidelines, rules, or agreements, try using group values. It's a way to reframe it a little bit, but I think the key is to really empower the group, if possible, to define what those are. And then you can be supportive of those and help facilitate the execution of those. Rules, values, goals, confidentiality. One of my roles, and one of the things that I would ask each group, even though it got redundant, I would remind the group that our group was confidential, and ask the group, what does that mean? If I had new members there, it would help define what that means. It means that what we talk about in here stays in here. And that doesn't mean that you couldn't take a concept or an idea that was discussed and share that with a family member or friend. But what we agreed on, that I would not identify anyone in the group to someone outside of the group. And then talking about the consequences, if those rules, values, or goals are not kept, what impact that can have. If I don't believe the group is confidential in a safe place, it's going to impact my willingness to be open and share with other group members, as an example. And then I really think there's some power in this too, trying to incorporate the group members' suggestions into the group values. We had a rule where in my men's group that if your phone went off in the group, that you would take your phone and turn it off and put it in the middle of the group room. And we had a little basket, and that was our way of the guys came up with that. That was not me. That was the decision of the group. Albert has his hand up. Albert?
Yeah, along those same lines, we use the talking circle format. And so instead of using the word like rules or agreements, the group came up with the title, How to Be in This Sacred Circle.
Yeah.
And so it kind of speaks to some of the teachings of the program, but how to be in this sacred circles.
That's wonderful. Yeah, it's almost like a meta process where you're talking about what the group is talking about.
Absolutely.
Yeah,
and how we're going to be while we're in this shared space together.
Yeah, that's fantastic. The other piece, the last point here on this slide is in a group setting, ethics and obligations to our patient safety still apply. So if a group member expresses an intent to hurt themselves or someone else, we still have to take appropriate action and seek support for that patient and make sure that everyone is safe. And there's been cases where we've had to really take some pretty swift action when we have a group member that's struggling, or there's activities happening before or after the group that we're placing other group members in danger. So we still have those are some of the responsibilities we have as facilitators in this field. And then just to build on that a little bit, try not to make group values rules too restrictive or too complicated. I think less is more sometimes. I used to say there were just three primary sort of expectations for the group, and one was attendance, and that's important. And the other one was participation, even if it's minimal, just that you're engaging with your peers and part of the group. And then the third one was that they came to the group in a good state of mind. In other words, not under the influence. And that was part of those three expectations that the group agreed were important. Again, we've kind of touched on this, but focus on the group's safety, looking at elements of being open and honest, having some consistency or some integrity, and then having that respect for each other in the group. There's some real power in that. And, again, beginning on time and ending on time, this is important. But again, I'm not going to bar someone from coming into the group if they were late. I had counselors on my team in the past that would, they were kind of old school. If you weren't there right when the group would start, they would lock the door and not let you come in. And that can sometimes be problematic. So trying to be flexible with that, but also, understanding and maybe making it a mindfulness component. Coming into the group 15 minutes late can be disruptive to your group members. Let's talk about that. Clarifying values. Asking questions like, what do I mean by establishing some rules or guidelines for the group, and what do we want? What do we want this group to be about? What do we want this group to be for? Those are some, I think, important elements that you may have some responsibility in defining. Being open to amending and adjusting, and being flexible and rolling with changes. And then I got into the habit too of, as I said, reviewing some of the expectations or goals for the group. Because it's an open group, we may have people starting that night, but even if we didn't, it was important to reinforce some of the group forms. Some examples just to consider, and I'd be happy to add some more to this list, but just some examples of group values. And again, I don't have to go through these, but just kind of soak those up a little bit, and maybe ask yourself, maybe an example, or think of a time when one of these came into play. I know in some of our residential groups, this one here, this willingness to accept feedback, there was a rule that if a peer was giving another peer feedback, then that peer receiving the feedback had to hear it out to the end before they commented or returned comments. So it was, those are just some examples of good group values or guidelines, just for your consideration. Also, just we're continuing along this line of implementing or executing group therapy, just providing an initial overview, both individually and in the group. Again, if I'm reviewing the group expectations with the patient before they start, then they're already coming in with an idea of what to expect, and what other group members are also aware of. Then the patient shows up and they already sort of know. And oftentimes I would have patients that had been in many groups, and oftentimes they would know, they would sort of have an idea of how a group worked. Where it became more important was in an entry-level outpatient group, or maybe in an early intervention setting where you either had a younger patient population, or maybe just a patient that had never been in a group setting, and they didn't know how groups worked. So it became important and at that point to sort of prep them before they came in, and then reinforce those expectations once they were a part of the group. Clinicians and patients can expect a greater degree of success. And I think that just is sort of a byproduct. And, I know success is kind of a relative term, but I think for a group to be successful, there needs to be some element of safety and support, and some element of consistency. And that's in the literature, it says this, and it's been my experience too, that's important. These are just some of the stages of group development. And these may be familiar to all of you. I don't know that we need to go through these verbatim, but just to give you an idea, I know this idea of forming, storming, norming, performing, and adjourning are basic group development sort of standards. And you'll see this on a lot of licensure or certification testing. So it might be good to just sort of be familiar with these. They're pretty intuitive, and they fit with what we've been talking about so far. In other words, early on, sort of building that rapport and establishing those expectations. And then as the group cohesion and working together increases, the facilitators' roles may change, and the group's movement and progress through their group experience will also evolve and change for the better. And I think it's important as well. I'm certain most of you could probably relate to this, but having closure, especially when patients are completing a group or graduating or stepping to the next level of care, how important it is to have closure in the group. I found many of the patients that I would work with would often have patterns or themes in their life where they didn't get closure with someone. So acknowledging and sort of, it doesn't have to be saying goodbye, but it could just be well wishes and really ending in a good way, I think was always important in that adjourning process. And it helps prepare those group members for moving on and having a positive experience in the group that they can remember and draw upon later in their recovery or in their treatment process. So again, we're looking at this theme of implementation of groups. In creating the group, remember that in most cases, you are sort of that common denominator in and with all the group members. So the group members may change over time, but you and or your co-facilitator are going to be the constants. And that's important. That reinforces the importance of your role and responsibilities as a group facilitator. It really is looking at you and your co-facilitator or colleagues shaping the group, your experience and behavior, as well as the expectations of the group members, will guide the formation of the group guidelines. And you're going to have, obviously some external or maybe agency expectations as well, but or a curricula to follow or certain goals you need to meet within the group itself. But your role can really shape the group experience overall and how it's executed and implemented. So in maintaining the group, you function as the mediator. You're handling issues that may come up, which may impact or interfere with the group's development. Usually the cases that I can think of is And this was when it was nice to have a co-facilitator, but if I had a patient that was intoxicated or under the influence, it was difficult to have them remain in the group. So to have a co-facilitator or support staff maybe take them aside out of the group and process with them and make sure they're safe and make a plan to either get them home or to get them into a detox setting if necessary. That's the one example I can think of where my role was really to make sure that the group was a safe and supportive place, and not to remove the intoxicated patient in a punitive way, but to really use that as even a discussion point after the patient in distress has stepped out of the group, allow the group to process what's happened. Your job is to really help the group function, and you having experience showing confidence and remaining calm and objective. And again, I can't stress the importance of providing that safe, supportive environment. You have some control over that, and it really can be an important element of the group's experience with you guiding them and walking them through that. So this is just an example, and I'm sure that many of you may have examples of your own, but this is just kind of a breakdown of a 90-minute continuing care group example. This is real close to the men's continuing care group that I did for many years at the clinic, and this just gives you an idea of sort of how it would break down. And did we go by this every single time? No, but it's pretty close. There might be some overlap or some changes, but this just gives you an idea of how that group agenda or that group sort of itinerary might look. And what was nice was, I would often put this up on the whiteboard, so that the patients would find some comfort in that ritual and that consistency. So they would kind of expect and know how the group would go, and it freed them up emotionally and I think cognitively to really be part of the group and experience being in the moment rather than having to wonder what's next. But you can see, here in closing, we may have a graduation or we may not. With an open group, sometimes we wouldn't have a graduation every week. So, but that's just to give you an example of what that group itinerary or that group schedule might look like. Just some common tasks of the group facilitator. Just again, there's a little repetitiveness here, but I think it's important to understand the role of the facilitator or co-facilitator. How many of you have experienced having a co-facilitator in a group that you've done? Anybody? It's a luxury anymore, but there's nothing better than a good yes, Catherine's got and Nick's got a co-facilitator. So it can be a luxury. A lot of times agencies don't have the staff for it. It's just not feasible to have two staff members in a group. But I find it, if you have an opportunity to have a co-facilitator, it's really advantageous for many reasons. But as a facilitator or co-facilitator, here are just some things to keep in mind. I may, again, I'm looking to create and maintain that safe environment. I may summarize or reflect, Jimmy, you mentioned to the group last week that you were looking for a job. How's that going? It's important for me to be able to remember and have a sense of history with the group. That goes a long ways, because then those group members know you're invested in what's going on with them. Sometimes staying in the here and now is an important element. It doesn't have to be all the time, but sometimes to bring them back to what's happening now. It can be very easy for the group to spin off and get stuck in the past or projecting onto the future. this is one too that I think can be difficult. My tendency is to want to solve it for the patient. Let me give you some advice and to tell you what to do. Well, if you can, and this works in an individual setting too, helping the patients discover the answers for themselves. And sometimes the peers will try and help each other out, but try not to solve the problem, but rather help them explore and discover those answers for themselves. Boy, it's okay to have fun in a group setting. You've got to do it. If you don't have a sense of humor in this profession, you may be in trouble, but you have to use some judgment too. You have to be careful and not go overboard, but being flexible and having a sense of humor is important. Redirecting war stories, I think, is important, especially in my men's group tended to be a lot of guys that were I won't say institutionalized, but they'd been in and out of the system and were very keyed in on how bad it was, and the man's got me down, and this is my PO, this and that, and you can get really stuck in sort of those war stories. So I would often challenge the group to focus on what they had some control over, and ask if they'd be willing to process that. If you can get the group to use I statements, you're doing well. They're sometimes they can be a little over the top, but it's important, I think, sometimes to practice using I statements. Again, breaking down maybe roles between the facilitator and the co-facilitator. Again, we're looking at the facilitator as sort of the lead. These may be some things that he or she is responsible for. And then we'll look at this next slide. And this is sort of the co-facilitator's role. This is an interesting one too. Anybody ever trained to not sit right next to your co-facilitator? Because you don't want the power vacuum to be right there. You sitting next to your co-facilitator. So I would try and make sure we sat on opposite ends of the room so that there wasn't, all this focus on the facilitator and the co-facilitator. But again, I think co-facilitator, it can be a great training opportunity and mentoring opportunity for a new clinician. And it can really be a great way to handle crisis situations too, and help monitor the time and just, be that kind of voice of reason if the facilitator is really, managing a high energy group or a high maintenance group. That co-facilitator can be a great sort of anchor point. So those are just a brief overview of some things to consider when we're talking about facilitating groups, the different types of groups, and some things to consider when delivering a group in whatever setting. But again, I'm thinking about a behavioral health setting. Just some elements or components to providing groups in a safe, supportive, and effective way. Let's shift now. We're going to go. I'm trying to look what we've got for time here. We've got about 30 minutes left. I want to move into the last section of slides here, and this is where I want the group members. I think Albert mentioned, he's working in a Native facility and with Native patients. So any of you that have some shared or some work experiences, please feel free to jump in and comment. I don't know what our chat box is doing. I just see some. Yes, that's great. Thank you so much. Yes, I love these comments. I haven't had a chance to stop and look at them. Yeah, so Catherine, I can imagine doing a couples group with a co-facilitator would be really important. Yes, that's great. I appreciate everyone's comments and keep them coming. And Parker, if you see anything pop in now, because I'm really asking for the audience's help here to help me move through this next section. I'm obviously not Native. And I want to make that clear. And my experience working with Native patients is limited. I had Native patients from time to time, and I've had colleagues and Native patients in recovery that I've attended groups with, but have not done a lot of direct service work with Native peoples. So let's just briefly sort of identify who we're referring to. Native American, American Indian, Alaskan Native, Native Hawaiian, First Nations, or other indigenous peoples. And just to give you a short overview, many of you know this on the call, and this number may have actually changed in recent years, but 573 federally recognized tribes in the lower 48 and 231 tribal communities in Alaska and within the Hawaiian Islands. It's important, and when I've consulted with our Native Advisory Council and my Native colleagues here at the center, it was made very clear that Native communication styles can be different, and that's important to keep in mind when we overlay that with a group dynamic or a group setting. So that's really what we're going to look at in these next series of slides as we move through today's presentation. Some things to consider, and again, I'm hoping to hear from the audience too. You guys feel free to jump in and add to the conversation. So some things to consider when we talk about Native communication styles. Communication styles for Native patients cannot be generalized. However, it is an important concept to discuss when working to improve providers' ability to work with Native peoples. Native patients are sometimes taught that listening rather than speaking immediately is important. And I have had a chance to experience this in some of our other virtual events, in our talking circle that we do the second Monday of every month. So I definitely think that is an important element to consider when we talk about Native communication styles. And I would ask anyone on the call here to jump in and add to this conversation as well. Some other things to consider: personal information about oneself and one's family is not easily shared, and this comes back to building that trust and understanding. Aside from the cultural component, silence or minimal sharing should not be taken as disinterest or an indication that something is not right. Where English is the patient's second language, the patient's speech, or when they share, may appear thoughtful or a slower cadence. And this again may be English may be a second language in some cases. And I don't know, again, Albert, or if others have some comments or thoughts about this, please feel free to add to the conversation. Some Native people or patients, especially elders, may believe that talking about a topic wills it to come true. And again, in talking with some of our Native Advisory Council and some of my colleagues here at the center, this idea has come up before, and that's why we included it in today's presentation. Some cultural considerations. The clinical experience builds upon and fosters positive therapeutic relationships. This is absolutely important in building trust. And it also increases the likelihood of adherence to maybe goals or treatment plan outlines that were established between you and your identified patient. And it it is likely to keep them returning and see the process to the end. Keeping their appointments, connecting with you it all comes back to trust and mutual trust between you and your patient, having that therapeutic alliance. I see it looks like a chat has come in. Yeah, Tony, I really appreciate that. You have to build trust. The youth will not talk unless they feel trust. That's your experience. Yes, I agree. I agree with that. I'm working with a lot of adolescents, not native necessarily, but just adolescents in general. Trust is important, and I think it speaks for the adults as well. It's hard to come by. Some other cultural considerations, we talk about this connection with the patient. It reaffirms the patient as experts in their own life. And I can't tell you the power of this statement in affirming with that patient that they are the experts, that it really is up to them to decide where we go. Absolutely vital. And in doing this, it helps the patients consider making some positive changes in their lifestyle choices, and it may improve or enhance their motivation to make change. Other considerations, asking yourself, how does this fit within Native worldviews? Most often, working effectively with Native people requires a shift in the delivery of services. And we could probably spend an entire webinar devoted to this topic and discussing this. The Western sort of linear kind of A, B, C is very different from a global sort of perspective. And that sometimes there can be a clash there between the Western approach and the Native approach from a cultural perspective. Asking, how do we work from a culturally relevant perspective? Other cultural considerations, the importance of spirituality. Often part of cultural teachings, both learned and ingrained in the community. And some examples could be, when there's a passing, or when there's a birth, or when there's rites of passage ceremonies. Spirituality is part of a holistic approach to wellness. Example, appreciation and respect for nature, environment, and surroundings, and appreciation and respect for our health, bodies, mind, and our connection to the past. Some other cultural considerations. This again is based on my discussions with our advisory council and some of my Native colleagues here at our center. There may be subjects that are considered off limits or taboo. HIV, for example, or sexual behaviors, or two-spirit sort of discussions. Those may or may not be something that can be discussed openly. Drug use itself, general issues of modesty and privacy, cross-gender communication. So some of the rules for communicating between men and women. Modesty is not about shyness, but about respect. And I thought those were all very poignant considerations to look at. Yes, thank you, Jude. She says, also don't assume that all natives are spiritual. This may cause defensiveness. Yeah, that's a great point. Thank you, Jude. I appreciate that. This was the kind of feedback I was hoping for. Some other considerations, Native specific cultural risk factors. This comes up from time to time, but maintaining confidentiality. Sometimes in smaller communities, this can be a challenge. Just lack of access to social services in rural or reservation settings. Other things to consider are just maybe limited access to healthcare, comprehensive healthcare. Also looking at circular migration, rural versus urban. Again, I think we also know that the impact that historical trauma can play on some of the connections to the past that are still relevant and are still, we see still being discussed and reviewed today. And again, elements of racism, whether it be xenophobia or issues surrounding sexuality or sexual identity. Let's see if we have any chats coming in. This is interesting too, and in talking with our co-director, Sean Baer, and others, you may have the opportunity to provide culturally respectful, meaningful mental health services. There is a pervasive and ongoing need for Native-centric or culturally sensitive mental health services research and anecdotally mentioned. You have the ability to know and understand trends and needs as a key role in this. And remember, we're talking about delivery of group services. So these are in the context of providing and delivering group services. How are we doing on time, Parker? I've got 1:15, so
I'm also looking at 1:15
we're
right
gonna
now.
we're gonna make it, ladies and gentlemen. And I'm hoping that we have a few moments to take some questions, or if folks want to unmute and join in the conversation. A couple of comments I want to make about engagement. One is in the idea or in the context of confidentiality. For some Native patients, it is an absolute barrier to care, linkage to care, retention in care, and continuing care. Does anyone have a comment about this or want to speak to this? It has to do oftentimes in talking with my colleagues, where you may have, your facilitator for the group may also be your auntie. So there can be conflicts of interests. It may be, your cousin may be in the group, or you may have somebody in the group in a smaller community. And it can really be a barrier to connecting in a group setting in the way that you would like to. Native people may have a personal family experience with breaches of confidentiality. So there may have been an experience where, there was a break in confidentiality because of what I mentioned earlier. It is critical that we maintain the highest level of confidentiality if we're serious about improving the quality of life for all people. So again, without confidentiality, group dynamics really suffer. And I think this is enhanced sometimes in Native groups, because you may have connection to people in the group or facilitating the group. And this happens too in mainstream society. We would often identify conflicts of interest. We can't have, a husband and wife attend the same group together, especially if there is a history between them of domestic violence or some sort of falling out. It's not in the best interest of the group or either of the patients for them to be in the same group. There are always exceptions to that, but that's just a general example. Using culture to help in the engagement process. And I have learned about this and experienced this firsthand, not as a clinician, but just understanding and being involved in cultural events, introductions, reaffirming them as experts in their own experience. Again, it goes back to that idea of really empowering them to understand that they are the experts in their own lives. Spirituality, opening and closing prayers. This are blessings. This is sometimes, we do this often with many of our events here, but it may be part of the group norm in a Native group or Alaska Native group, where the group is started with an opening blessing, song or drum. Albert, I don't know if that's, I'm sure that's part of your talking circle. It starts that way and maybe ends that way. But deciding who's going to do that and, arranging that ahead of time, or maybe it just happens, spontaneously, but you may have to lead it yourself too, is what I've seen also happen with some of our groups and events that we've done here at our center. I really love this. I was taught to embrace silence and pauses. So this 10-second rule just sort of inherently fits with my own understanding. But if I ask a question, I allow for at least 10 seconds for a response. There's a propensity to want to just keep it moving. Having a referral list of local Native organizations, showing up for a Native event, whether it be a powwow or maybe a dinner or a fundraiser or something, but being part of that. It's a two-way street. Providing some refreshments if possible, and having other incentives involved may help engage Native patients a little more. And these incentives, and this is also used for non-Native patients as well, but offering assistance with transportation can be a big, removal of a big barrier. Food or gift cards. A lot of the literature speaks to the patient-provider relationship regarding incentives. Is the patient seeking services only for the incentives, or is the patient personally motivated? And that can be difficult to discern. But again, if we go way back to what we talked about, voluntary versus involuntary, those answers may be revealed pretty readily. As long as the patient is returning for services, you have a golden opportunity to engage and build trust. And I think that transcends cultural considerations, but I think it really is a key factor in working with Native populations. And Mike's got some good comments here. You guys can read this. In our group environment, there's often the involvement of family or other relations being introduced at different times. I have encountered a few times when this would become toxic and the individual would remove themselves, or someone would have to be asked to leave the meeting. Mike, I agree. Sometimes there were patients that I had where it was better that we didn't involve the family, at least right away. So I think that's something to consider. I appreciate you sharing that. Yeah, Rachel, I agree. Even if they only show up for the incentives, they may still benefit from the actual activities. I agree. I completely agree with that. Just again, when we talk about retention or building that investment so that patients will stay with us to hopefully meet the requirements of their referral source, or to reach a point where they don't need us anymore and they can move forward without our help. But some retention strategies, building relationships with community leaders. Because consistency is vital in building these relationships. Be prepared to inform them of your program, intent, and progress. Give ample time to process information and to ask questions. Again, getting local organization support, outreach with face-to-face visits. If you can, meet with them face-to-face, phone calls, emails, or I don't even know if anybody faxes anymore. Oops. Does anybody send a fax anymore? I don't know if anybody does. No text, emails, or calls. If you can, reach out face-to-face. Now, with the pandemic, we've had to adjust there, but it's important to meet face-to-face. If it's a new organization, start at the top. So go to that CEO or that clinical director, and it may take multiple attempts. Integrating cultural activities such as dancing, beadwork, shawl making, circles, and cooking traditional foods. Again, we're talking about retention strategies when working with Native communities or Native patients. And this can be a great way to build a therapeutic relationship, trust, connection, and knowledge. Taking the professional out of the professional and creating more of the personal. And again, this, you have to walk that edge, that fine edge sometimes where you have to maintain some borders and some professionalism, but I think sometimes you have to set that aside for a moment and try and connect on a more personal level. It's just, you have to be careful with that too. Again, some more ideas connected to retaining and getting that investment from your patient, reminding patients of Native specific cultural strengths. This can build motivation, courage, and healing. I've been told that Native patients don't hear this information often enough, and it's important to reinforce and make that part of the conversation. I've taken a quote here from one of my colleagues. She said, "I believe Native people know these strengths because they are demonstrated in stories among our elders and through our ceremonies." I thought that was very powerful and really important for me as a non-Native to keep that in mind. Sometimes it just needs to be pointed out, reminded, and built upon. And so those are some things connected to, and then there's just a few other ideas here, things to keep in mind, to be knowledgeable about, to have an understanding about, even if you have to consult with a Native colleague or a family member, to have a better understanding so that you're not misappropriating some of this knowledge or understanding when trying to connect and build that therapeutic alliance and relationship with your patients, and to keep them engaged as best you can. That sort of wraps up. I put a few references here, but that wraps up the primary presentation. There's a couple of, if any of you have seen this book, this is a good one. This is the Stages of Change group treatment for substance abuse services guidelines. It's based on the DiClemente Stages of Change model. It's just a great, we used to call this the purple book at my clinic. Everybody had a purple book. It's a nice manualized Stages of Change group. This is the other, if I know Samson does a lot of publications. This Tip 61 is a great one. I think I listed that, yes, I listed that on the slides, but if you can get a copy of this or in PDF, this for me was a valuable resource. Behavioral health services for American Indians and Alaska Natives. This was written by and large by other Native professionals, and is just a wealth of knowledge. So I really value that. The other one, this is a little dated, but it's called Joining Together. This is a nice overview. I think I list that one in. Yes, I did. I listed this one as well. This is a great overview of group therapy and group skills. So there's so many resources. The last one I'll plug is another SAMHSA publication. This is sort of fundamental, but it's TAP 21. And there's TAP 21A too. I just don't have a copy of it, but this is really, it's a nice overview of substance use disorder counseling competencies, and really speaks to some of those core functions. So those are the recommendations I would put out there. And if you can get your hands on a copy of Tip 61, I would really encourage you to do that. Whether you're native or non-native, I think it's got a lot of information that might be valuable to your practice. Okay, well, look at that. 3 minutes to spare. If you have other comments or questions, you can reach out to me or our center here at the College of Public Health, or our project program director, Dr. Shinstad. Any questions or thoughts? I see a couple of chats popped in here that I'm just noticing now. Oh yeah, Parker's put our survey in there. I really appreciate that. Thank you, Tony. I appreciate your direct message. Yes, groups for me have been one of the most powerful elements, not just in my professional career, but also in my own recovery. I can't imagine recovering and being in recovery without the power of the group. My recovery has to come out of me. It can't stay between my ears. I'm in trouble if I keep it to myself. We have a saying in my recovery circles that we keep what we have by giving it away. And it took me a while to understand that, but this happens in the group setting. So your patients will benefit greatly. And you'll be doing a wonderful job as a facilitator when your patients are doing all the talking and you're just sort of there to guide them along. That's when you know you've really mastered the group. And so I encourage you, if you get a chance to observe a veteran facilitator, to watch them, and to share your knowledge as a veteran facilitator with your colleagues and folks entering the field for the first time. Thank you very much, everybody, for your time and consideration. Reach out to me with questions or comments. We're going to make these slides available to you post-event. You can also request some CEUs. We'll offer 1.5 NADAC-approved CEUs for this event. And we will also give you a chance to fill out that wonderful survey when we reach out to you via email. So again, I want to thank everyone. It's great to see some familiar names and faces. Next month, we're going to be doing, Dr. Ken Winters will be presenting on the adolescent brain and substance use disorders. So please join us for our September Esas. I'll probably see many of you on some other events at some other point this month. Until then, I want to just say thank you to everyone for attending today. And until next time, please be safe, stay connected, and stay healthy. So thank you very much.